I think I'll start with the presentation. Hi, good evening, everyone. I'm Liya, speech and language pathologist at Indocare Health Center. Today, I will be presenting Beyond Shyness, an introspection into the world of selective mutism. And I hope this will be meaningful and insightful for all of you joining us today. We will start by understanding what selective mutism is and trace its developmental journey and how and when it typically emerges in children. And then we will explore its causes and contributing risk factors, its impact on everyday life, and the key symptoms and the behavior signs. We will also look at differential diagnosis because selective mutism is often confused with other conditions, followed by assessment tools and evaluation methods. Then we will discuss the critical role of speech therapist along with classroom strategies, accommodations, and practical tips for both parents and teachers. And finally, we will address common mistakes to avoid the prognosis. It's a comprehensive journey, so let's get started. Moving to the historical background, it was originally called elective mutism, meaning that children were choosing not to speak. That word elective suggested it was a willful behavior, but in 1990s, that term was officially replaced with selective mutism. It acknowledged that these children are not choosing silence, rather they are unable to speak in certain situations due to overwhelming anxiety. Moving to the definition and overview, it's classified as anxiety disorder where the children can speak in their comfortable settings and struggle to speak in social situations, which means it is a diagnosable clinical condition, not a personality trait, and certainly not a bad parenting. It typically begins before the age of 5, making it an early childhood condition. However, it often goes unnoticed at home because the child speaks comfortably in familiar environments. We will only know when the child enters the school and faces increased social demands. And that brings us to the last point, social demands, the transition to the school environment where the children are expected to interact with teachers and peers are often the trigger that brings selective mutism into light. This is the official definition of selective mutism. According to DSM-5, for a child to be diagnosed, all of the following criteria must be met. First one is consistent failure to speak in specific social situations in which there is an expectation for speaking despite speaking in other situations. This 1 minute. The disturbance interferes with educational or occupational achievement or with social communication. The duration of disturbance is at least 1 month, not limited to the first month of school. The failure to speak is not attributable to a lack of knowledge or of comfort with spoken language required in the social situation. The disturbance is not better explained by a communication disorder, example childhood onset fluency disorder, and does not occur exclusively during the course of autism spectrum disorder, schizophrenia, or any other psychotic disorder. There is something happened with my computer. Let me again open the window. Okay. In terms of prevalence, the studies estimate that selective mutism affects approximately 0.11% to 2.2% of children. When we look at the gender, selective mutism is commonly identified in girls than in boys. Regarding the age of identification, the onset is typically around 3 to 4 years of age, often becoming most visible when the child enters school or daycare for the first time and is suddenly expected to communicate in an unfamiliar environment. Importantly, selective mutism frequently co-occurs with other conditions, particularly social anxiety disorder, separation anxiety, and specific phobias. This is why differential diagnosis is so essential. And finally, there is a higher incidence among bilingual and immigrant children. The pressure of learning new language and cultural environment can significantly increase the anxiety, making these children particularly vulnerable. So the selective mutism does not affect all children equally, and awareness of these demographics helps us to identify and support the right children at the right time. As we say about bilingualism in our previous slide, we will see the link of selective mutism and bilingualism. There is a common misconception about the relationship between bilingualism and selective mutism. Although selective mutism is more common in bilingual children, speaking two languages does not cause this condition. It's important to distinguish between the normal quiet period that can occur when learning a second language and the ongoing difficulty speaking in specific situations, that is characteristics of selective mutism. Selective mutism across development. This timeline shows how the selective mutism may look at different ages and why support needs to change as the child grows. In early childhood, when it's age like 2 to 5 years, children may speak normally at home but speak very little or not at all in other places. They may still close to their parents and use gestures, pointing, facial expressions instead of words. This is often when selective mutism is first noticed. And when it comes to the school age between 6 to 12 years, the children usually talk comfortably at home but remain silent at school. They may find it difficult to answer questions, ask for help, or speak in class because they do not speak. Others may wrongly think that they do not understand or know the answers of the questions that the teachers is asking. Moving to the adolescence, 13 to 18 years, some teenagers may speak more than they did when they were younger, but anxiety is still present. They may avoid presentations, group discussions, and social situations. This can affect friendship and school participation. The core takeaway is like the selective mutism evolves with age. Early identification and stage appropriate intervention are essential to prevent the condition from being enriched and socially limiting over time. And moving to the causes and risk factors, there are three factors. First is biological factor, may include anxiety in the family, an overactive fear center in the brain, and a naturally shy or cautious temperament. And moving to the environmental factors, may include overprotective or anxious parenting, stressful or upsetting life experiences, major life changes, and pressure to speak or perform in unfamiliar situations. Psychological factors include extreme shyness or social anxiety, fear of being embarrassed or judged negatively, and perfectionism, along with a strong fear of making mistakes. Moving to the neurobiological perspective, this is a science behind the silence. The recent neuroscientific research reveals that selective mutism is directly linked to the brain, to how the brain processes the fear and the social threat. Three key neurological findings are heightened amygdala activity. The amygdala is the brain's fear center that is getting overactivated in individuals with selective mutism and triggering an intense threat response in social situations. Second one is reduced activation in speech-related brain areas. Under this social stress, the regions responsible for producing the speech become suppressed, making verbal communication neurologically inaccessible to those moments. And a third one is the freeze response. The resulting state is not willful silence, but a genuine neurological freeze that completely blocks the ability to speak. When it comes to the impact of on daily life, there is impact will be there on academic performance, social development, and emotional well-being. In academic performance, the children with selective mutism may find it hard to take part in class. They may not answer questions, join group work, or complete oral test. The teachers may think that they are not interested, which may lead to less support and lower expectations. And moving to the social development, these children may have few friends and can feel socially isolated. They may struggle to talk to peers, share their needs, or express their feelings. This can sometimes lead to bullying or being misunderstood or making them feel left out. Emotionally well-being, the children may start to feel that not speaking is their fault. They will feel like it's their fault, and this can lead to frustration, guilt, worry, and low confidence. If not supported early, these feelings can become stronger and may lead to depression. Some culturally sensitive considerations we must be looking into, because without that maybe we will think that that's a symptom of selective mutism. So when assessing selective mutism, a child's culture should always be considered. Different cultures have different rules about speaking, silence, and social behavior. Being quiet does not always means there is a problem. So we must look to the eye contact. In some cultures, avoiding eye contact is a sign of respect, not anxiety. So it should not always be seen as a symptom. And speaking to elders, in many cultures, children are taught to speak less or not speak directly to adults as a sign of respect. This can sometimes be confused with selective mutism if culture is not considered. Moving to the public speaking, some cultures encourage children to be quiet and reserved in public. So, speaking less in groups may be a normal behavior, not a disorder. The key point is, without understanding a child's culture, normal behavior can be wrongly seen as a problem. Moving to the differential diagnosis, social anxiety disorder is often seen as a severe form of social anxiety. Both this SM and this both involve fear of being judged and avoiding social situations. They often occur together, so careful assessment is needed to distinguish between the child is having SM or the child is having social anxiety disorder. Trauma-related mutism, this can look similar because the child does not speak in both cases. However, trauma-related mutism happens after a stressful or traumatic event, while selective mutism is mainly linked to ongoing anxiety. So the causes and treatment of both trauma-related mutism and selective mutism are totally different. Moving to the autism spectrum disorder, there can be some similarities in communication and social skills. But autism also includes other features, like autism has sensory sensibilities, repetitive behaviors, which is not part of selective mutism. And speech and language disorders, it's a least overlap. The children with speech or language disorders having difficulty producing the speech. So in selective mutism, the child can speak, but anxiety prevents them from speaking in certain situations. Moving on to the symptoms and behavior indicators, there are three symptoms mainly. Verbal symptoms, the most common sign of selective mutism is not speaking in certain places, such as school or public settings. A child may whisper, speak only to a trusted people, or give very short answers when asked questions. The child is able to speak, but the anxiety make it difficult in certain situations. Moving to the nonverbal symptoms, the children with selective mutism often communicate through body language instead of words. So they may avoid eye contact, have limited facial expressions, appear stiff or tensed, and use gestures, nodding or pointing to communicate. Emotional and social symptoms, the children may experience social anxiety in social situations, avoid group activities, have low confidence, and feel frustrated because they cannot express themselves easily. Although these feelings may not be obvious to others, they can greatly affect the child's daily living and well-being. So the symptoms of selective mutism is a verbal, non-verbal, emotional and social areas, and can greatly influence a child's daily functioning and overall well-being. There is some issue with my screen sharing, so I'll share one more time. Yes. Moving to the common characteristics, child may show the following behaviors when struggling to say thoughts, feelings, or opinions. So the behaviors are they will show extreme shyness, minimal eye contact, lack of social engagement, temper tantrums, response latency, withdrawing or hiding, staring blankly, clinging to parents, acting silly or goofy, or rubbing their eyes. Sometimes a child will become emotionless and expressionless when trying to communicate. This behavior is particularly common at the beginning stages of selective mutism. Nonverbal communication may be stronger than verbal communication in new settings. A child with selective mutism, they are not shy, they are not being stubborn or refusing to cooperate, they are not deliberately oppositional, they are not, their silence is not caused by poor parenting. The condition usually does not go away on its own without support. They are not choosing, no, they are not choosing not to speak. So the main message is that the child is not misbehaving. They are struggling with anxiety. They need understanding and proper support, not punishment or the assumption that they will eventually get over it. Moving to the diagnosis, here is the key steps professionals use to properly diagnose selective mutism. There are three main parts of assessment process. First one is detailed developmental and family history. The assessment begins by gathering a full background on the child's developmental milestones and family history. This helps to identify any early signs or related factors that may have contributed to this condition. And moving to the second one, observations across multiple settings. Professionals observe the child's behavior and communication patterns in different environments such as at home, at school and in clinic. This is important because selective mutism look different depending on where the child is. Third one is the interview with parents, teachers and caregivers. Interviews are conducted with the key adults in the child's life to gather their perspectives and insight on the child's behavior and communication challenges. And moving to the assessment tools commonly used, there are four main tools professionals use to assess and diagnose selective mutism. First one is Selective Mutism Questionnaire, a standardized tool used to assess the child's speech patterns across differential settings. And second one is Anxiety Disorders Interview Schedule, a comprehensive interview used to diagnose anxiety disorders, helping to confirm whether the selective mutism is present alongside other anxiety related conditions. School speech questionnaire is the third one, which specifically evaluates the child's speech behaviors and the level of impairment they experience at school. And moving on to the fourth one, this behavioral observations. Just directly observe the child's speech patterns across multiple environments at school, at home, and in clinical settings. And moving on to the treatment approaches, selective mutism is treated using four main approaches and they work best when combined. The first one is speech and language therapy done by a speech language pathologist They help the child improve communication skills and gradually build confidence to speak in different settings. Behavior therapy, that is done by psychologists. They work on reducing the anxiety and slowly help the child become comfortable speaking in situations where they usually stay silent. And pharmacological treatment done by psychiatrists, they may prescribe medication in some cases to help to reduce the anxiety, especially when symptoms are more severe or other therapies are not enough. Moving on to the fourth one, the family and school support. Parents and teachers create a safe, supportive, and low pressure environment at home and in school, which helps the child feel more comfortable speaking. All these four approaches work together to support the child's progress. Moving to the role of speech and language pathologist, SLPs play a crucial role in supporting the children with selective mutism, mainly focusing on three areas. First one is functional communication, helping the child communicate more effectively in everyday situations. And second one is confidence in expressive language. So we build the child's ability and confidence to express themselves verbally. And third one is social pragmatic skills, developing the child's ability to use language appropriately in social situations. So importantly, the SLPs do not work alone. We collaborate closely with psychologists and teachers to provide a comprehensive multidisciplinary approach to treatment, ensuring the child receives consistent support across all settings. And I will be explaining the techniques widely used for selective mutism. First one is cognitive behavior therapy. This technique helps the children with selective mutism to warm up, feel comfortable, and begin interacting with their clinician. So it's known as PRIDE. So P is for praise. For praise means give labeled specific praise rather than general comments. Instead of saying good job, say something like thank you for telling me you are drawing a castle, or wow, I like how you are using so many colors. So you can use like this words instead of doing like saying some usual words like good job, like that. So this makes the child feel like truly seen and encouraged. And moving to the R is for reflection. Repeat back what the child says to show that you are listening. Also reflect the noise and sounds the child makes, such as like if the child says a blue car, so you can repeat that, and you can say beep beep. So this validates the child's communication, whatever form it takes. And I is for imitation. Simply do what the child is doing. Joining the child in their activity builds connection and trust without any pressure. And D is for describe behaviors. That means narrate what you and your child are doing together. For example, you can say like if you are doing some block activity, you can say you are stacking the red block on top of the blue block, or like if he is drawing a picture of sun, you can say like you are drawing, so you can say I'm going to draw a picture of sun. This keeps the interaction natural and low pressure. And E is for excitement. Show genuine enjoyment and enthusiasm. Responses like "That's so cool" or "What a house you built." So encourage the child and make the session feel safe and fun for the child. There is two key interaction phases used in cognitive behavior therapy. That is child directed interaction and verbal directed interaction, and we can see specific do's and don'ts for each phases. And child directed interaction, the clinician participates in an activity alongside the child without any communication expectations. This helps the child to adapt to a new communication partner or an environment. It's especially useful for warming up or when the child is feeling uncomfortable. So in this you can use pride strategies, the one we saw before, and you can play and have fun with the child, but don't ask any questions or don't prompt the child to speak in child directed interaction. And when we are moving to verbal directed interaction, after the child become more comfortable for almost like 5 to 10 minutes, when he become comfortable, you feel that he is comfortable, you can the clinician takes a risk and asks a question using specific question types to generally encourage verbal responses. In this, you can use pride strategies, and you can ask forced choice questions and use a direct prompt and have fun with the child. But don't ask yes or no questions, and don't allow a non response, and don't use any indirect questions, and don't mind read or speak instead of the child. Usually, we use many question types in therapy. Here it explains which can be used and which can be avoided. There is X or no questions. Try to avoid this as they allow the child to escape the verbal communication through gestures or head nods. Early, when we are doing a therapy early, gestures and nods can be accepted, but this should be quickly eliminated. For example, like do you want to color a picture? So he will head nod, or he will use some gestures for the thumbs up or something like that. So maybe initially you can do that, but later you should avoid it. You are able to hear me, right? Can you give a thumbs up? Okay, so moving to the next one, forced choice questions. One of the most useful tools when working with children with selective mutism. It simplifies language demands and models the correct response for the child. For example, you if you are asking, do you want red, blue, or something else? So there is a chance that he can answer any question, or maybe he will say something else. So you can use that. This is the one of the most useful question types you can do with selective mutism. And moving on to the open-ended questions, more difficult as they allow for unscripted responses. Child may generate their own answer without a model. For example, what color do you want? So mostly it's difficult, so it's better to avoid that. And indirect questions should be avoided because they give the child the option to respond or not respond, making it easy to say silent. For example, I wonder what color you will pick next. So this should be avoided. Indirect questions should be avoided. And moving on to the direct prompt, often avoided unless working on a specific speaking task. It directly instructs the child to speak. For example, tell your teacher what color you want, or tell me with your brave talking. So this all you can use, but according to the specific speaking task you can use that. Otherwise avoid that. So here mostly we can use forced choice questions above all the questions. Forced choice question is the best question you can work with the children with SM. And main message is that not all questions are equal. Choosing the right type of question at the right moment is a powerful clinical tool. It can either gently encourage the speech or unintentionally allow the child to avoid it altogether. And next technique is fade in or fade out. It's a behavior technique used to help the child with selective mutism transfer their ability to speak from a safe person to a new person. For example, a safe person parent to a new person, maybe a clinician or a teacher. So fade in, how can we use fade in? This is a process of slowly introducing a new person into the child's comfortable space. The child and parent play a game alone in the room, and new person enter the room and sits away from the child and engaging in another task to appear busy and non-threatening, and the parent and the child can continue playing. If the child keep answering the parent's forced choice question in a new person's presence, new person gradually moves closer and the parent continues prompting the child to verbalize, and new person then begins child directed interaction with the parent and the child. At this point, new person can give some stickers or points when the child verbalizes, and then the new person starts verbal directed interaction and asks the child a force choice question. If the child answers, they you can respond with thanks for telling me and give a sticker or a point. How we will see how fade out will work. This is a process of gradually removing the parent from the session. For example, if the child is coming every day with a parent in the session, so you can do this gradually. Remove the parent, so parents start moving back and taking less of a lead in the activity. Parent may need to sit in a room but away from the child, and parent leaves the room briefly, like making a phone call or going to the bathroom, like that she can show that she is going to make a phone call and all. So the new person continues playing with the child using verbal directed interactions techniques. So maybe the child will not notice that immediately, that when the parent leaves a session. So you can use that in case of in that situation. Next one is shaping communication. It is a step-by-step progression of building communication in a child with selective mutism, starting from complete silence and gradually moving towards full expression. Like there are four stages. First one is non-communicative, that is a frozen one. The child is completely still and silent, so no sounds or not gestures at all. So moving to the stage two, non-verbal sounds. The child begins making some sounds but without words, like grunting or laughing, coughing, clicking tongue or humming, all that kind of things. Stage 3, non-verbal communication. The child starts communicating through body language and tools. For example, eye gaze, head nods, pointing, gestures, thumbs up, or writing or AAC. The transition to verbal communication begins here by imitating oral movements like sticking out tongue or opening the mouth. And the half step in that one is mouthing the words, means the child moves their lips as if he is speaking, but no sounds comes out. Then we can go to imitate voiceless sounds. You can use voiceless sounds before whispering. So the next half step, the last one in the stage 3 is whispering one. That means the child produces a quiet voice, and so some sound comes out even though it is very soft. So after this whispering, you can move to imitating voiced sounds. And when we move to the stage 4, it's a pure verbal communication. So child moves into actual speech. That time you can do sound by sound imitation, blending into single words, forced choice single word responses, forced choice multi word responses, and at last you can go for open-ended responses. Next technique is desensitization technique. It's a gradual low pressure intervention technique used to help the children with selective mutism become more comfortable using their voice in situations that they find challenging. The primary goal is to help the child move from fear and avoidance of speaking to comfortably verbal communication. By providing repeated calm exposure to speaking opportunities, desensitization helps to reduce anxiety and the freeze response, teaches the child that speaking is safe, and build a confidence over time. This approach is based on several key principles. The child is never forced to speak, and the communication demands are kept low to minimize pressure. Intervention begins in safe and familiar environments, often involving a parent or preferred activities or a play-based interaction. As the child's confidence increases, the level of challenge is gradually increased. So common desensitization techniques that can include are audio recording activities, video recording practice, telephone or walkie-talkie conversations, barrier activities like such as using the puppets, dividers, or speaking from another room, and distance fading techniques in which therapist gradually becomes more involved while maintaining child's comfort and success. Next one is gradual exposure hierarchy. Presents a step-by-step progression showing how a child with selective mutism is gradually guided from no verbal communication all the way to speak confidently in classroom settings. Each stage built on one before it. On the one before it. Okay. Step one is non-verbal communication. Begin with the child using nonverbal methods to communicate, such as gestures, pointing, or writing. This is a starting point where there is no pressure or speaking at all. So step two is whispering to a trusted person. Gradually encourage the child to whisper to a single trusted adult in a safe, comfortable settings. So this is the first tiny step towards using their voice, because in previous step we are not pressuring them to speak. So this one they can use their voice. And third one is speaking quietly in a small group. Slowly increase the number of people the child speak to, maintaining a small supportive group environment. The child is not alone here, but still in a low pressure settings. And moving to the step four, speaking to a teacher alone. Have the child practice speaking one-on-one with the teacher in a private setting. This builds confidence with an authority figure before expanding it to a larger audience. So step number five, speaking in front of the class. This is the final goal, and the child speaks freely in front of larger classroom setting. This is achieved only after successfully building confidence through all other previous steps that we discussed. There are some supportive bridge strategies. Presents three additional strategies that serve as a bridge to support a child with selective mutism, helping them communicate and stay connected while working towards a full verbal communication. All three are meant to be temporary support or not a permanent solution. This is used as a temporary, not a permanent one, used as a bridge, not a long-term solution. So play-based, first one is play-based group therapy. It's natural, enjoyable play activities are used with the child's best friend that the child already talks during play. This relaxed, familiar environment lowers anxiety and encourages spontaneous communication. And moving on to the other one, remote therapy or home therapy. Many children with selective mutism speak more freely on video calls or at home than in person or in school settings. So therapy delivered remotely or at home takes advantage of this comfort zone to build verbal skills in a less threatening environment. And you can use AAC tools such as communication apps or devices are used as a bridge to prevent the child from being excluded academically or socially while they are working towards the verbal speech. It ensures the child can still participate and express themselves meaningfully. So these are the three techniques that you can use as a bridge, not for a long term. Moving on to the classroom accommodations. This provides practical specific accommodations that teachers can put in place to support the child with selective mutism in the classroom, reducing anxiety and allowing the child to participate and demonstrate their knowledge without penalized for their silence. So you can use allow the recorded responses or written answers. So you can give the child alternatives to speaking aloud, such as recording their answers or using responses or a communication passport. This ensures the child can still express what they know. And you can do like you do not call on the child unexpectedly, like avoid putting the child on the spot by calling on them without any warning, as this can significantly increase their anxiety and trigger a freeze response. And you can use, before I said, you can use forced choice questions or choice boards. Provides visuals that allow the child to communicate through non-verbal means such as choice questions or choice boards. This helps the child engaged and participating without requiring spoken language. So when they have a speaking task, you can give advance notice. This can provide the child with ample time to prepare for any speaking task, such as class presentations or group discussions. Preparation reduces surprise and lowers anxiety. And you can accept the pointing, the typing and drawing initially. So you can start by allowing the child to communicate through gestures, typing or drawing, and gradually build up towards verbal responses at the child's own pace. Next one is like grade knowledge separately from verbal participation. So you can assess the child's academic knowledge independently from their verbal participation to avoid penalizing them for their selective mutism. These are the general tips that you can follow. Allow time for each response. You can give like 5 to 8 seconds for the response time for these children. And the goal is not to get the child to speak. So always keep that in mind. The goal of the child is to be comfortable, because when they are comfortable, they can speak. And child is never forced to speak and is always encouraged with positive reinforcement, and avoid direct eye contact initially. What not to do in selective mutism. There are some actions that can increase the anxiety and reinforce the mutism. So that must be avoided. So first one is that force the child to speak. So this is the most harmful action of all. Forcing the child to speak triggers the freeze response and deepens their fear. It never helps and always makes things worse. Next one is label the child as shy in front of others. Publicly labeling the child reinforces their identity as someone who does not speak, or increases their embarrassment and making it even harder for them to break out of their silence. So don't do that. And next one is punish silence. Punishing a child for not speaking sends the message that their anxiety is a behavior problem, when in reality they are not choosing to be silent. This adds shame on top of fear. Speak for the child constantly. So always speaking on the child's behalf removes any opportunity or motivation for the child to try communicating themselves. Next one is that praising the speech excessively. Overpraising a child's speech can create performance pressure, making them more self-conscious and anxious about speaking again. These are the long-term outcomes and follow-up. Here we can see what happens after the treatment, covering the positive results of intervention as well as ongoing care needed to maintain the progress. It is presented in 4 key areas. First one is positive outcomes. With consistent intervention, 70 to 90% of the children with selective mutism show significant improvement. This is an encouraging and hopeful statistics that reinforce the value of early and proper treatment. The second one is that importance of early treatment. Earlier treatment is directly linked to faster the progress in overcoming the selective mutism. Sooner a child receives the right support, better and quicker their outcomes tend to be. So next one is ongoing monitoring. Continued follow-up and support is important to prevent relapse during major life transitions. So such as if he is changing the school and getting a new teacher or moving to a new environment, these transitions can trigger setbacks even after significant progress has been made. And moving to the next one, risk of relapse. The children with selective mutism may experience setbacks in situations with increased public speaking demands or unfamiliar social situations. This is normal and expected, and that's why it highlights why long-term monitoring matters, and even after the child has improved. So there is a chance to get it relapse. So long-term monitoring is essential. There is some research. This is research-based findings on long-term recovery of children with selective mutism. So here you can see a bar chart comparing the recovery rates across multiple studies. In this long term, the recovery rates for SM are relatively good in a long term. However, other disorders, mainly anxiety disorder, were commonly found to develop later in life, even after selective mutism is improved. And next one is that early detection and treatment are essential to prevent symptoms from persisting and to stop other psychiatric disorders from developing alongside or after selective mutism. And third one is family well-being and family dynamics matters here. The child's family environment should always be considered during treatment, as many family-related factors is associated with the poorer SM selective mutism outcomes. And changing school sometimes help the children from recovering their sum. They suggest that school-based factors such as bullying, negative peer relationships, or an unsupportive classroom environment can actually sustain and worsen the SM symptoms. So sometimes it will be good for the child, sometimes it will be bad for the child. So long-term follow-up is very critical, providing the child with SM ongoing support and more opportunities to communicate may play an important role in preventing the future problems and maintaining the progress they have already made. Here I'm concluding my presentation with three essential things to keep in mind. The first thing is that selective mutism is serious. It's deliberating and should never be minimized or dismissed. Second thing, selective mutism is treatable with the right understanding and intervention. The child can and do recover. Third thing is that the key to help these children lies in empathy over judgment, seeing their silence as anxiety and responding with patience, evidence-based support and compassion. These are my references. And that brings us to the end of my presentation on selective mutism. I hope this has given you a clearer understanding on what selective mutism is and how we can play an important role in supporting them, whether as a clinician, as a teacher, or a caregiver. So thank you for your time and your attention today. And we are now open for any questions you may have. Please feel to ask out loud or drop your questions in the chat box.
Liya, there are some questions in the chat box.
Yeah. There is a question that difference between selective mutism and social anxiety disorder. Selective mutism and social anxiety disorder both are anxiety disorders. In this selective mutism is like the child have difficulty in certain situations, speaking difficulty, and social anxiety disorder is like they will feel like they will be judged by others, or they will feel like they will feel like they are negatively seeing them instead of they are not positively seen by the others, so they will feel negative in all the time. And the next one is that selective mutism communication difficulty is the most difficulties that we have seen. But in social anxiety, that is other than communication difficulties, many other areas will be affected in social anxiety disorder. I think I answered that question. If you have any more doubt, let me know. Um, and next one, how will we know it's selective mutism or shyness? Shyness is a personality trait, but SM is an anxiety disorder. For shyness, if you can see a child is going to school, in the initial 2 3 months, they will like they will join with the class, they will start speaking with their friends and all, but SM is like still they are consistently going with the same, not talking to others or to their friends, to the teachers, and that's with familiarity also they are not getting improved, so that is beyond shyness. So if it is happening after 1 2 months with the same class, you can check for an assessment with is it selective mutism or not. So I think I answered two of the questions in the chat box. If you have any more questions, let me know. Do you think the psychologist and psychiatrist are essential in intervention for kids in with SM? Psychologist is essential, but psychiatrist is optional because how much is the severity of the issue will be taken care of in case of psychiatrist, but psychologist and speech language pathologist are essential for treating for intervention of, because they know more about anxiety disorders and all, so they should be there. I think if you don't have any more questions, we can wind it up. So thank you, everyone. I think I answered your questions, and it's time to wind up. Thank you all. Thank you for listening. Thank you so much.